In this session we'll discuss diseases of cornea. Bacterial keratitis, ulcer. The most frequent causative agents are Staphylococcus aureus, Pseudomonas and Streptococcus pneumoniae. Signs vary with the severity and on causative agents. Signs include lid edema, marked ciliary congestion, epithelial breakdown followed by stromal suppuration. Ulcer usually starts as a circumscribed infiltration and edema of the surrounding tissue is seen. Margins are overhanging and the floor is covered by necrotic material. Overall look of the ulcer is wet. Hypopyon may be present in variable amounts with flat borders. This picture depicts infection with Pseudomonas, and here we can see a corneal ulcer with impending perforation, and this here is a perforated corneal ulcer. Corneal abscess is a localized suppuration in the deep stromal under intact corneal epithelium. It is usually associated with staphylococcal infection. Treatment of bacterial keratitis is by scraping and smear preparation to identify the microorganism quickly and then prompt initiation of therapy with frequent, that is hourly, topical broad-spectrum antibiotics. Other therapy includes atropine, treating secondary glaucoma. Therapeutic penetrating keratoplasty in extreme case. Fungal keratitis or keratomycosis. The causative agent may be filamentous fungi or candida, typically preceded by ocular trauma with agricultural and vegetable matters. Relatively painless, dry-looking, elevated yellowish-white lesion with indistinct margin. Delicate, feathery, finger-like projections into the adjacent stroma is seen along with massive dense hypopyon which is immobile with convex upper border. Slowly progressive stromal destruction may lead to corneal perforation with its sequel. Candida keratitis is characterized by gray-white infiltrate, often as collar button abscess, similar to bacterial ulcer. In filamentary keratitis there is typical feathery appearance with finger-like projection and satellite lesions. Demaciaceous fungal keratitis often produces pigments on the surface of the ulcer. Fungal keratitis is treated using topical antifungal agents. Natamycin 5%, amphotericin B 0.15%, or voriconazole every 1 to 2 hourly. May require therapeutic penetrating keratoplasty in severe cases. Acanthamoeba keratitis. Very rare unilateral keratitis that typically affects the soft contact lens wearer. Characterized by radial keratoneuritis where there is progressive chronic stromal keratitis with recurrent breakdown of corneal epithelium. Paracentral ring-shaped ulcer or abscess is the mark of advanced infection. Treated using PHMB, that is polyhexamethylene biguanide or propamidine isethionate, neomycin, chlorhexidine, etc. May require therapeutic penetrating keratoplasty in severe cases. Sequel of corneal ulcer or nebula, macula, leukoma. Leukoma, adherent leukoma, anterior staphyloma, phthisis bulbi. May require therapeutic penetrating keratoplasty in severe cases. Dendritic keratitis seen in herpes simplex virus initially starts as superficial punctate erosion which coalesce. They send out lateral branches with knobbed ends, to form dendritic, or tree-like figures, and this is pathognomonic. Bed of the ulcer stains with fluorescein, and the swollen diseased cells at the margin take up rose Bengal stain. Treated by debridement, topical antiviral acyclovir, mild cycloplegic, oral acyclovir to prevent recurrence. Geographical keratitis are characterized by larger epithelial lesions known as geographical or amoeboid configuration. May occur as a continued enlargement of dendritic keratitis. Likely to occur following inadvertent use of topical steroids. Treatment is similar to dendritic keratitis. In stromal necrotic keratitis there is cheesy and necrotic appearance of the stroma. May be associated with epithelial breakdown and anterior uveitis. Vascularization, scarring and even perforation may occur. Treated using oral acyclovir, topical antiviral, cycloplegic and judicious use of topical steroids. Metaherpetic keratitis, trophic ulcer. Occurs due to persistent defects in the basement membrane. Margin is gray and thickened due to heaped up epithelium. It is not an active viral disease. Treated using artificial tears and bandage contact lens (BCL). Disciform keratitis. Deep keratitis with disc-like edema. It is an immunogenic reaction to herpes simplex virus. There is focal central stromal edema with fine keratic precipitates. Presence of decimase folds and increased central corneal thickness in severe cases is seen. Wesley's immune ring surrounding the edema in long-standing cases can be seen. Treated using topical steroids, full strength or diluted, with acyclovir eye ointment in equal frequency along with cycloplegic. Herpes zoster ophthalmicus. Characterized by vesicular eruptions around the eye, forehead and the scalp. Hutchinson's rule states that when the tip of the nose is involved, the eye will also be involved. Ocular lesions may be acute, chronic or recurrent nummular keratitis, multiple granular lesions surrounded by a halo of stromal haze. Treated by oral acyclovir 800 mg 5 times daily for 7 days. Topical steroids in keratitis or iridocyclitis and systemic steroids in neuro-ophthalmological problems. Lagophthalmos or exposure keratitis. Owing to dryness and desiccation, the lower third of epithelium is cast off and the raw areas invaded by microorganism. Seen in facial palsy, leprosy, proptosis thyroid exophthalmos, comatose patients, etc. treated by lid taping, tarsorrhaphy, lid load operation and treatment of the cause. Neurotrophic keratitis occurs in the anesthetic cornea which alters the metabolism of the epithelium. Mostly seen in herpes simplex and herpes zoster keratitis. Punctate epithelial erosion involving the interpalpebral area can be seen. There will be edema and exfoliation followed by epithelial ulceration. Treated by ointment and patching. In severe cases amniotic membrane transplantation or tarsorrhaphy. Marginal keratitis or catarrhal ulcer. Caused by hypersensitivity reaction to staphylococcal exotoxin. Subepithelial infiltrates at the periphery, mostly at 4 to 8 o'clock position, or at 10 to 12 o'clock position. Treated by topical corticosteroids, steroid antibiotic ointment and simultaneous treatment of blepharitis. Vesicular ulcer. Our flictannular ulcer slowly migrates towards the center of the cornea in a serpiginous way and carries a leash of blood vessels which lie in a shallow gutter formed by the ulcer. Treated by topical corticosteroids, cycloplegic and topical antibiotics. Interstitial keratitis is the inflammation of the corneal stroma without primary involvement of epithelium or endothelium. It is a rare bilateral condition, seen in syphilis, tuberculosis or Cogan's syndrome. Characterized by vascularized, midstromal, non-suppurative inflammation, giving a ground glass appearance. In the inactive stage, there is variable stromal scarring with ghost vessels. Hutchinson's triad includes interstitial keratitis, deafness and Hutchinson's teeth, which is a part of congenital syphilis. Treated using systemic penicillin, topical steroids and cycloplegic.